to detect early squamous cell carcinoma. Okay? Why Papa Smith? Because we use a special stage Papa Nicolau. Okay. The second question comes, what are the cytological features of viral infection? Yeah, you will tell me they are called coilocytes, pycnotic, or a little bit big nuclei with clear hollow surrounding it. Alright? Now, the second question, what are cervical carcinoma? What is the histological type, the most common one? It is squamous cell carcinoma. We have adeno, but the most common is squamous cell carcinoma. Then, what are the progression levels of the squamous cell carcinoma in intraepithelial in cervix? Yes? You tell me, previously was CIN1, CIN2, CIN3. Now they combined it to low-grade and high-grade squamous intraepithelial lesion. What is low-grade? Low-grade, they included the viral infections of non-oncogenic viruses, or it can be oncogenic virus that will progress. So when we have low-grade, we just repeat it after a short while. If it was low malignant potential virus, it will go regress. If it was high, it will progress. When I come to the high is more than CIN2 and CIN3. It means carcinoma in situ. What I will do? I will do biopsy with acetic acid. If it is papillary, I will see papillary. Okay? Now, and another question, what is the etiology of a squamous cell carcinoma in cervix? You tell me the most common viral infection, oncogenic viruses 16 and 18. Okay? Now about invasive cervical carcinoma, micro and invasive. The micro 3 mm, 7 mm, invasive I know. Okay? So this is whole everything I can ask about cervical carcinoma. That's very common question in all exams because it's a very important tumor and we have a screening program all around the world. Okay? Now, another one from cervix. I can put picture of squamous metaplasia with Nabothian cysts. I tell you what is this, you tell me chronic non-specific cervicitis. I tell you what do you see, squamous metaplasia and Nabothian cysts. Why do I have Nabothian cysts? Because in the squamous metaplasia, the orifices are closed. Okay? Now, I come to the endometrium. I will ask, what is endometriosis? What is adenomyosis? Okay, these are common words we use a lot. Now, then I will put a picture or I will ask, what's the difference? Endometrial hyperplasia, endometrial carcinoma. Both the etiology is estrogen. I will always ask etiology with all these tumors. Yeah? If the etiology is estrogen, then what is endometrial hyperplasia? Proliferative phase and proliferated gland, a stroma. It can be with or without atypia. Without atypia, it's like hyperplasia we know with cystic dilations here. With atypia, it is carcinoma in situ. We call it endometrial intraepithelial neoplasm. Okay, please learn the words because you will read. These are the new. Now, when in future they will change, you will know, but you must know the base. Now it is intraepithelial, endometrial intraepithelial neoplasia. It is with atypia, which is carcinoma in situ. And always remember, the basement membrane is intact. In the invasive endometrial adenocarcinoma, it's like any other adenocarcinoma. What do I have? 3 grades. Grades are important. You will read well, moderate, poorly. This is the easiest one. We already know. In any adenocarcinoma, anyone asks you how do you give grade, what do you will think? Glands and cytological features of malignancy. All adenocarcinomas. Okay? In endometrium, I put them in grade 1, grade 2, grade 3 according to the percentage. In prostate, I put it in Gleason, but in all, what I will look for, glandular formations and cytological features of malignancy. Okay? So this is about endometrium. Now, I come to this is a very common question, classification of bladder tumors. Yeah? Remember, how did we put them? We give them invasive, non-invasive. The non-invasive, always remember in bladder. any papillary structure has potential for malignancy. Yeah, if you remember this, you can start. Non-invasive papillary, non-papillary flat. The flat tilled carcinoma in situ, we know it. Now the papillary, without atypian, remember you have malignant potential. So what do we call it? Papillary intraepithelial neoplasm of low malignant potential. Once low-grade and high-grade dysplasia starts, I change the name into intraepithelial carcinoma. Yes, papillary. Low-grade, high-grade. It depends on the grade of dysplasia. Always remember, in this male-female, we have low-grade, high-grade. This is a very common word. They changed it, okay? Because they are combining these grades 1, 2, 3. They saw that the grade 1 has prognosis, 2, 3, the same prognosis. Okay? For invasive urothelial carcinoma, always remember, what's the histological type? Transitional cell carcinoma. In all tumors, I will ask, what's the histological type? Again, you will read, it is transitional cell carcinoma. In invasive, what I will look for the muscular invasion. Why? Because the staging is changing in the muscular invasion. So always look for the muscular invasion, because you will change the stage. Okay? Now, for the prostate, benign and malignant, we did it together with 2 students. What's the difference? I can put picture, gross and micro. What's the etiology? Excess androgens. Yes? We know this. We did it with 2 students, it's the same. I can put pictures and tell you, this is prostate, which one is benign, which one is malignant. Or I can tell you, compare between benign, prostatic hyperplasia and adenocarcinoma, according to location and according to the microscopy. Then I can ask, what is Gleason, what is the grading system of prostate? You tell me Gleason and give me how. Any questions for prostate? You did. For seminoma, I will put picture. Yes? First, you tell me family. What the family? You tell me germ cell. What do we see? Pale with lymphocytic infiltrate. Yeah, that's the differential diagnosis from clear cell carcinoma of the kidney. Now, another one for germ cell tumor, teratoma. I can ask in different ways. Give me two tumors of germ cell tumors in male, you tell me seminoma and teratoma. I can ask separately, what is teratoma? Tell me. You start, family, germ cell. Yes? In male and female, and when I say, tell me the family. In the gastrointestinal tract, I will not ask because it's all adenocarcinoma is epithelial. Yeah? But here you must know. This is germ. Teratoma, it's 3 layers, mature tissues, each one from endo, ecto, meso, at least. Yes, I divided it to mature and mature. If it is immature, I will look for the age of the patient, young or adult. Adults, the prognosis has malignant potential. Okay? So, this is about, then come to the kidney. For the kidney, we did it like the pre-test. Yeah? I will have questions, except that I think Dennis sent you nephrotic and nephritic syndrome. That's the only question. Yes, I will ask. What's the difference? Give me 2 examples. That's theory. Now, for the pictures, we have it. Yes? I will put it and do it together again. It's like the pre-test. Yeah? The same. The new pictures are few. I will send you in the weekend. Yeah? New pictures, maybe for seminoma, for hyperplasia, or so pictures. From my PDF, but I will put it together so it will be easy for you to study.